Yeah, today we are going to discuss about the muscles and structure in the lower thoracic or lower pelvic region. So, you will be able to see here, these are the main muscle you will be able to see in the posterior structures. Last day we had discussed about the thoracolumbar fascia that is seated all over here, and we are going to discuss about the erector spinae and some other muscles like gluteus maximus, which have a role over the hip, also which will assist in the lumbar movements. So the posterior muscles, as we already discussed about the thoracolumbar fascia, I am not going to point about this, that is thoracolumbar fascia. So we'll discuss from the erector spinae. The erector spinae, or it is composed of the longissimus thoracis and iliocausalis lumborum. The function of these muscles are described as which have a attachment over the thoracic area. Here it is called as thoracic area, and over the lumbar area. So the longissimus thoracis and the iliocausalis lumborum pars thoracis form the more superficial layer, and the longissimus thoracis pars lumborum and the iliocausalis lumborum pars lumborum form a deep layer. It's like basically they are classified as a superficial layer and a deep layer. It is easier to group the muscles together as a superficial layer and the deep layer. The superficial layer runs from the ribs and the thoracic transverse process to the muscle bellies that is located in the thoracic region. See, it is coming from the ribs and it is traveling through the thoracic region. The muscle region have long tendons that join together to form the erector spinae aponeurosis, which inserts into the spinous process of the lower lumbar spine, sacrum and iliac crest. So as I described, when a muscle that is structured or which is oriented in the posterior direction, see, these are the muscles which is directed in the posterior direction. So can you just imagine what can be the role of this muscle in the posterior structures? Of course, it will be pulling the structures or joints towards the posterior compartment. If it is in the perpendicular or it's a exact posterior muscle, it will be pulling towards the back side. If it is coming towards the posterolateral, which means the muscle action will be towards the posterolateral. For example, one muscle is the Quadratus Lumborum, which we are going to discuss in the next slides. So this superficial layer with its long moment arm and excellent line of pull produces extension of the thoracic and lumbar region when acting bilaterally. These muscles are considered to be as a primary extensors of the trunk. See here, it is starting from here and getting attachment over the lower part of the vertebral column, that is sacrum. So as I told, the action of the muscle, can you just see, it's a exact posterior muscle. If it is acting bilaterally, if the bilateral muscles are acting properly, you can see it will be able to go to the extension of the vertebral column from the cervical area to sacrum. From lumbar area, the movement will be starting. So acting unilaterally, they are able to laterally flex the trunk and contribute to the rotation. So I would like to highlight this point. Acting unilaterally, they are able to laterally flex the trunk and contribute to the rotation. So why I highlighted the point is just because, just imagine if the one structure, like one muscle structure, for example, this is right and this is left side of a person. So if the right sided muscle, that is posterior muscle, is acting more, just imagine if it is acting more, plus and left side is just acting plus, that is, it is compared to the right side, the left side is acting very minimal, which makes a difference. If it is acting unilaterally, they will be able to laterally flex the trunk and contribute to the rotation. So if one side of the muscle is going for tightness, what happens is it will be able to laterally flex the trunk. So this you should be able to understand, or it had to keep in your mind. If a muscle is overacting, if a muscle is therefore symmetrically there, but if a muscle is overacting, it means it will be able to produce another action. This can be one of the reason so many of the people are getting back pain. Sometimes people are getting, ASI, not ASI, posterior pain, like, SI joint strain. So there are more chances if this muscle act unilaterally more. They just given a point that if they are acting unilaterally, they'll be able to support or they'll be able to assist in the lateral flexion. But you have to think in such a way that what if the muscle is overacting in one side? So during this trunk flexion from a standing position, the rectus spinae are responsible for contracting eccentrically to control the motion. But before that, when you're standing upright, when you try to, extend your trunk, first muscle which will be acting will be the gluteus maximus. But here during the trunk flexion from a standing position, the rectus spinae are responsible for contracting eccentrically to the motion. See here. So if a person is standing, is in the upright position, then he had moved to the bending position. Like from upright position, he had turned and he had took the body into a bending position. So what happens is this erector spinae, here becomes a erector spinae, that is the posterior muscle where, so you will be able to see the erector spinae. Erector spinae will be going towards the gravity. As I mentioned, if a muscle is elongating and an external force is acting, here the external force is gravity. Gravity will be pulling you down. So if an external force is acting and the muscle is elongating, there occurs the eccentric contraction of the muscle. So here the eccentric contraction of the erector spinae occurs, as well as it have to control the trunk movements. So the gravitational movement will produce a forward flexion, as I mentioned. But the extent and ratio of the flexion are controlled partially by the eccentric contraction of the extensors, that is the posterior muscles, with the erector spinae aponeurosis, and partially by the thoracolumbar fascia, which is situated almost over the here. Combination of the latissimus dorsi and ipsilateral gluteus maximus and the posterior ligamentous system. Now the point you have to keep in your mind, the erector spinae that act eccentrically until approximately 2/3 of the flexion movement, and afterwards it will be like which a point becomes electrically silent. There will be a point where the erector spinae will be electrically silent. So this area is called as this phenomenon is called as the flexion relaxation phenomenon. So I would like to double underline this situation, because just imagine if your erector spinae is not elongating. For example, if your erector spinae is tight over any area, so what will happen? So until and unless if you are reaching till the end point, approximately 2/3 of the maximal flexion, erector spinae have to eccentrically contract. Just imagine within this, before reaching the 2/3 of the maximal flexion, what if the erector spinae is becoming more tight? So the person won't be able to bend further. So as the flexion is progressing, the erector spinae won't be able to elongate further, and there is a point where the erector spinae is electrically silent. So just imagine if your muscles are so tight and the eccentrical contraction is going to stop at a point, there are more chances the patient can get the lower back pain due to this situation. At a point, the eccentrical contraction of the erector spinae will be silent, and that point is called as flexion relaxation phenomenon. But if your muscles are getting tight at that point, there are more chances the people can get back pain. You might have seen so many of your relatives or your friends might have complained when they are bending, they are getting back pain. So these points should be there on your mind. And which is thought to occur at a point when stretched and deformed passive tissue are able to generate required movement, as we had discussed in the last slide. The extensor muscles may be relaxed only in the electrical sense, because they may have generating force elastically through the passive stretching. That's what I was telling. If the muscles are getting tight, this passive stretching may not occur. The control of flexion becomes the responsibility of the passive elastic response of the erector spine aponeurosis, the thoracolumbar fascia and the posterior ligament system. The posterior ligaments like supraspinous and intraspinous ligament, which have a longer momentum than do the extensor muscles and thus have a mechanical advantage over the extensor. That's what I was telling. When you are learning the first chapter, you should be able to understand what do you mean by the momentum and what do you mean by torque. You should be able to differentiate how much each muscles will be able to produce a particular amount of torque. So this deep layer of the erector spinae are being entirely separate from the superficial layer and consists of the individual fascicles with the common tendons insertions. The deep erector spine has similar in orientation and function to the levator scapulae, that is in the cervical region that we had discussed. And this muscle lies close to the axis of rotation and therefore they do not have the sufficient momentum to be the prime movers into the extension, which means the difference in the momentum which will affect the particular actions of the muscle. Their oblique orientation, however, allows the muscle to exert a posterior shear force on the vertebrae. In the addition to the posterior shear, they also exert the compressive forces. The same way, this compressive forces as well as shear force you have to learn from the first chapter, then only you will be able to understand what we are talking here. Here we go with the full lumbar spine flexion. The muscle lose their oblique orientation, therefore lose their ability to resist the anterior shear force. So anterior shear force means it will be in this plane. So a flexed spine therefore is unable to dynamically resist the anterior shear forces which can cause damage. The same way I am going to underline this point. A flexed spine therefore is unable to dynamically resist anterior shear forces which can cause damage. The same way you might have heard the complaints from either your family members or some of your friends. When they are bending forward, sometimes they may get the pain because the flexed spine they won't be able to dynamically resist the anterior shear force. So that can even cause the damage to the lower back area. The multifidus muscle of the spine are complex and demonstrate the segmental and regional differences. The lumbar multifidae that run from the dorsal sacrum and the ilium in the region of the posterior superior iliac spine, that is over here, that is somewhere over here, and which is going to the spinous process of the lumbar vertebrae and have separate fascicles. So you will be able to see the muscle here. Now we are going to discuss the lateral muscle. As I had mentioned, one of the lateral muscle that I really want to talk about is the Quadratus Lumborum. When you are getting a lower back pain patient or when you are getting a sports patient, you have to check in and around your lumbar area as well as over your hip area. So the major muscle that you may missed out is the Quadratus Lumborum, because whenever a patient they are getting the back pain, most of the time they will be having a flexion pain or an extension pain. That time we won't even take care about the lateral muscles. That's what I had underlined in the first slide. Unilaterally, when their extensors are acting, there are more chances they can laterally flex the trunk. So just imagine if the right side, this is the right side of a person, if the right side, the posterior muscles are getting tight compared to the left side. So if the right side is acting more, which means it will be able to rotate the trunk as well as it will be able to laterally flex the trunk more oftenly. So the action of the Quadratus Lumborum is to laterally flex the trunk. So when you are combining these two situations together, there are more chances the Quadratus Lumborum can act more than any other muscles. So we'll talk about the Quadratus Lumborum. It is a deeper than erector spinae and multifidus muscle. The Quadratus Lumborum, when acting bilaterally, serves as an important frontal plane stabilizer. The Quadratus Lumborum has also serving an important role in stabilization in the horizontal plane also. When acting unilaterally, Quadratus Lumborum can laterally flex the spine. So as I mentioned, the posterior structures, if they act unilaterally, they will be able to laterally flex. In the same way, if the Quadratus Lumborum is acting unilaterally, it will be able to laterally flex the trunk. So when you are standing or when you are giving a extra force towards both the sides, both the Quadratus Lumborum had to act, in a simultaneous way. Just imagine if one side of the Quadratus Lumborum is acting, this side will be pulling much. So there are more chances if Quadratus Lumborum is tight. In most of the scoliosis patients, which means the lateral curvature, more lateral curvature will be there for the spine. Most of the scoliosis patient, one side of their Quadratus Lumborum will be always tight. So here, as you mentioned, it can unilaterally act as a lateral flexor of the spine. So I'm just taking the same point whatever I had mentioned in the first slide. What if the posterior structures are getting tight in a unilateral area? For example, my right side area, if posterior structures are getting tight, it will be able to laterally flex and rotate the spine. So in the same way, if they are doing the phenomenon, obviously the Quadratus Lumborum will be activated unknowingly or without our knowledge. So there are more chances Quadratus Lumborum can go for tightness. So this can be one of the reasons why we are getting lower back pain. So if the lateral flexion occurs from the erect standing and the force of gravity will continue the motion, the contralateral Quadratus Lumborum will control the movement by contracting eccentrically. The same way we mentioned for the erector spinae. If you are standing like this and if you try to flex your body or the vertebral column towards one side, the gravity will be assisting this movement, but the opposite side Quadratus Lumborum had to control the movement while doing the eccentrical contraction. It can also control the rotational motion due to its attachment to the lumbar transverse process. If the pelvis is free to move, the Quadratus Lumborum will hike the hip or laterally tilt the pelvis in the frontal plane. See, it has a role of controlling the rotation or the rotational movement. So just imagine if you are standing on one leg. Of course, the Quadratus Lumborum had to stabilize this area. Or else if the Quadratus Lumborum is weak, there are more chances we can collapse or we can fall down. Now we are going to discuss about the anterior structures. The main anterior structure muscles are the abdominal muscle, which have a connection over the pectoralis major, which will be having a connection over the pectoralis major. The rectus abdominis, that is a prime flexus of the trunk and which is one of the important muscle which will be able to stabilize the hip in its alignment. For example, if your abdominals are weak and if you are getting a big tummy, what happens is the abdomen won't be able to control the hip in its position and it will go for further anterior pelvic tilt. So that the hip flexor will become tight as well as the erector spinae will be becoming tight. So it is contained with the abdominal fascia which separates the rectus abdominis into section and attached results in the abdominis aponeuros of the abdominal wall. The abdominal fascia that also has attachment to the aponeurosis of the pectoralis major that I had mentioned in the few seconds before or few minutes before. The importance of this facial connection as they transmit the forces across the midline and around the trunk. So I would like to underline this line also. The abdominal fascia that have attachment of the aponeuros of the pectoralis major. Importance of this, I'll just underline this point. Importance of this facial connection, they transmit forces across the midline and around the trunk. So how can we correlate this situation? I can correlate this situation with the sports if you want. For example, if a fast bowler is coming and bowling is action. See, the action is like from the shoulder, you will be releasing a ball, but not in the shoulder, sorry, on the wrist you will be releasing the ball, but the shoulder action should be initiated. The same way it have an attachment. See, now if you bowl, like this, which means like horizontal adduction will occur when you bowl like this. So what happens is the transmission of the force from the wrist, that is controlled by the pectoralis major when you are going at the horizontal adduction. So as we had mentioned, this abdomen is having an attachment over the pectoralis major. This importance of this facial connection as they transmit forces across the midline and around the trunk. So obviously the force or the torque produced by the pectoralis major will be transmitted down, that is towards the trunk area, that is prime plexus. Obviously the abdominal muscle have to get activated. This is just for your knowledge I am telling. When, for example, when a person is bowling and if the muscle is getting activated, the pectoralis major is getting activated, obviously that muscle torque will be transmitted towards the abdominal muscle or towards the trunk through this connection. That's why I underlined the point. The importance of these facial connections are as they transmit the forces across the midline and around the trunk. So the tension of this facial system will provide the stability similar to that provided by a corset or around the trunk. This abdominal wall consists of the extensor oblique, the internal oblique and the transverse abdominal muscle. This muscle together we are calling as the hoop, which around the entire abdominal muscle, the abdominal wall as the anterior aspect of the thoracolumbar fascia and its muscle attachment as the posterior aspect. This hoop plays an important role in the stability of the lumbopelvic region, as I had explained. If your abdomen is not strong enough, see the abdomen is over here till the hip area. Just imagine if abdomen is getting weaker, it won't be able to contract it in its original pace. So what happens is the neutrally aligned hip will be tilting anteriorly like this. So example, if the hip is tilted, if the hip is oriented in this direction, that is normal direction, if your abdomen is not able to control the hip in its normal position, what happens is the hip will be tilting more in front, that is more anteriorly it will be transmitted, or it will be tilting more anteriorly, that is more anterior tilt will occur. So what happens is the spine won't change its alignment, otherwise the spine had to bend. In order to prevent that, the spine will go for more lordotic curve. Just listen it properly. If your abdomens are not working properly, or if abdomens are getting weaker, just imagine this as a hip. The abdominal muscles are over in front of the muscle. This is the anterior part of the hip. This is the posterior part of the hip. Abdominal muscles are situated over the anterior part of the hip. If the anterior structures are getting weaker, the hip will go further in front because of the activation of the hip flexor. So what happens is, in order to compensate this posture or alignment, the vertebral body will be going for more lordotic curve. Otherwise, the vertebral column had to come in front. This is what we have to connect the lumbopelvic rhythm. If the hip is moving in front, automatically the lumbar area also have to move. So if the hip is moving anteriorly, in order to compensate the movement, the vertebral column will be going more lordotic curve. So if the lordotic curve is getting increased, usually the muscle should be in its elongated position. So what if the lordotic curve is getting increased? Automatically the erector spinae muscles will be coming tight. So the erector spinae muscle, see this erector spinae muscle become tight, that is over here erector muscle become tight, as well as the hip flexor also will be becoming tight. Hip flexor also will become tight. So this abdominal muscle will be going for a weakness of abdominal muscle, as well as the hip flexors also will become weak. So this is what we call as lower cross syndrome. The tightness of the erector spinae and hip flexors will lead to, or it can associate with the weakness of the abdominal muscle as well as hip flexor. That is lower cross syndrome. It is like a cross. The cross muscles are getting involved. The back posterior muscle, that is erector spinae, and the flexor are getting tight. Abdominal muscle and the gluteus maximus are getting weakened. So this is what we call as erector, that lower cross syndrome. So the transverse abdominis that has been shown to mechanically control the sacroiliac joint through the significant compressive force due to the transverse, or it is a perpendicular. See the perpendicular movement, orientation of the muscles to the joint. You will be able to see the perpendicular orientation of the muscle. So the Richardson and colleagues demonstrated that the contraction of the transverse abdominis decreases the laxity at the sacroiliac joint. So I just want to underline this point. They are telling when this muscle, that is transverse abdominis, is contracting, there will be decreased laxity at the sacroiliac joint. So just reverse the order. What if the transverse abdominal muscle decreases its tone, or it is reducing its strength? So same, the reverse will happen. If it is contracting, the transverse abdominis is contracting, there will be a decreased laxity at the sacroiliac joint. So what if the abdominal muscle is contracting very less? There will be increased laxity at the sacroiliac joint. So you will be able to understand if a person is getting SI joint dysfunction, you just have to check the transverse abdominal muscle strength also, or you have to check the orientation or the tenderness of the muscle. So Cholicki and the colleagues demonstrated that in a neutral spine posture in standing, there is trunk flexor extensor muscle coactivation at a lower level. If you are standing erectly, the trunk flexor extensor muscle will be acting in the lower level. So furthermore, they showed that this activation level increases with an external load and with a decreased spinal stiffness, which supports the hypothesis that this hoop can provide stability to the lumbopelvic region, and that decreased muscle activity can compensate for loss of stiffness in the spinal column that is caused by the injury. The psoas major, one of the important muscles which I want to explain. The psoas major, which runs from the lumbar transverse process, you will be able to see the psoas major transverse process, the anterolateral vertebral bodies of the T12 to L4, and it is descending down to the lesser trochanter of the femur. You will be able to see here. The primary role of this psoas major is the hip flexion. The iliacus runs from the iliac crest over the pubic ramus to the lesser trochanter with the tendon of the psoas major. So this is the muscle activation when you are doing a sit-ups. So when you flex the muscle, already the muscle will be in its shortened position. So this area will get stabilized when you are keeping the hip and knee in the 90-90 position. So this is the normal activation of abdominal muscle when you are flexing your hip, but make sure you have to contract your rectus abdominis. So what if the lordotic curve had increased? That's what the figure had shown. If the lordotic curve had increased, there will be reduced activity of the abdominal muscle. That's what I explained in the few slides, 2 slides before, I guess. The more anti-tilting will occur, instead of the abdominal activation, the rectus femoris activation will be more. Excuse me. The primary role of the iliacus is also the hip flexion. The role of psoas major at the lumbar spine appears to be buttress of the force of the iliacus, which when activated causes the anterior iliac rotation and thus the lumbar spine extension. The psoas major also provides the stability of the lumbar spine during the hip flexion activities by providing greater amount of lumbar compression during activation. Here it comes, if you are starting with a lumbar flexion, it will compress the particular vertebral bodies. So the psoas major also, okay, the same, some